Good morning, everybody, on this snowy day in New York. Thank you for joining us again. It's a real pleasure to have Bernardo Cortese from Milano join us. Bernardo is an expert in PCI, complex PCI, everything around coronaries. He's also been very instrumental in drug-coated balloons, leading many clinical studies in Europe as PI, and to try and really bring drug-coated balloons into standard day practice. So I really like your title today, Bernardo, PCI and surgical turndown patients. I love the fact about surgical turndown in quotes like that. So yeah, thank you for taking the time and spending an hour with us. We really appreciate it.
Yeah, Azim, thank you very much. You are a good friend. I'm really happy to join you and your team and the fellows here today. And I have to admit that probably I surprised you with this title, huh? Because this is not something, you could expect something about CTO, DCB, or whatever. No, no.
Yeah.
This is an important setting of patients that are going in the mindset of the interventional cardiologist for surgery, but then the surgeon decides not to treat them. And this is, I would say, a really neglected population of patients, and trying to provide you a case, and from this case also some clinical data about what's happening in this patient population. So the case is about a woman that arrived at our hospital a few years ago during pandemic number 2 in Lombardy, and she came with acute coronary syndrome. The symptoms were mostly dyspnea. So in the emergency room, we did an echo showing what the CG already had shown, which is the quite high hypertrophy and this depressed left ventricular ejection fraction 30% with the severe calcific aortic stenosis on top of the MI non-STEMI that she had. So after stabilization, we brought the patient to the cath lab, finding this quite complex three-vessel disease. Mostly the left main, distal left main, was highly calcific and diseased. This was the LAD with a calcification in a proximal part and the diffuse disease. So what we did was to stop this 80-year-old patient. We decided not to treat in the cath lab by means of PCI. We also have to underline some blood examination showing a mild anemia, 10.5 grams of hemoglobin, and a mild renal insufficiency with a creatinine 1.4. So we brought the patient to the heart team discussion, and as expected, the cardiac surgeon decided not to treat this patient due to several comorbidities. So which is the fate of this patient? We have a pivotal trial that was published something like 10 years ago on circulation, aiming to assess and to understand which is the fate of these patients which are excluded by cardiac surgery. So in this single center study, they underlined the fate of 218 patients which were not treated by surgery due to several comorbidities, mostly poor target vessels or poor bypass possible conduits, advanced age, renal insufficiencies, severe lung disease, and anemia, cancer, whatever. These are the main reasons for excluding these patients from cardiac surgery. However, the fate of these patients that have not been treated by means of revascularization is really, really bad as compared to patients that can undergo normal cardiac surgery. You can see here that mortality is dropping down during the first few months with a difference versus eligible patients, which is maintained up to 3.5 years of follow-up. So which are the current challenges with patients not eligible for surgery? First of all, the prevalence of this type of patients is increasing, and according to some registry data, 1 out of 5 patients is refused by the cardiac surgeon, going from 1 out of 3 to 1 out of 10, according to the experience of the center. Then there is an increasing sensitivity also in public reporting of the outcome after any type of surgery to our patients. And what is quite important in the US, the metrics of the hospital. There is also an advancement in the CHIP patients, mostly in the cath lab. So we are investigating new therapeutic options in this type of patients, not only by means of new devices, but also by a good teamwork with the anesthesiologist and the ICU. And then we don't have a specific risk model that is able to capture all of these variables, allowing us to understand clearly, prospectively, which will be the fate of these patients. Guidelines, either the European ones or the US ones, are not helping us in deciding which is the correct fate of these patients. And then when we decide to take the duty of these patients after the refusal of the cardiac surgeon, we don't have a real consensus on what to do in this type of patients. What about the completeness of revascularization? Data not from CHIP patients or complex patients or refused patients, but data from the syntax trial are showing clearly how the more you complete the revascularization, the better is in terms of freedom from any type of event. So we should try to be complete in these patients, but on the other hand, we have the problem that we have to spare contrast dye to reduce the length of the intervention and reduce any possible complication in this type of patients. Recently, it has been presented and published the Optimum study. And sorry for this. Surgical ineligible patient in a US center. So these patients underwent PCI 726. PCI, the primary objective of this study was to assess the 30-day or in-hospital mortality in this PCI cohort, comparing it with the predicted STS surgical risk. All of these patients were analyzed by our team. There was an independent CEC, and there was also an independent core lab for the assessment of the baseline characteristics. So in these patients, independently assessed STS was 5.3% mortality at 1 month, whereas the surgeon's predicted mortality was 10.4%. So double then that the one expected by the STS. And this is the first important finding. How were the angiographic characteristics of the patient population? The calcifications were really severe. There was a lot of bifurcations, 80%, a lot of CTOs, 56%, long lesions. Syntax score was really, really terrible. And from the procedural point of view, we had quite a big number of stents implanted in this patient population, 3.2 per patient, a lot of left main. CTO 20% versus CTO by angio was 56. This means that complete revascularization was not achieved in many of these patient population. A lot of atherectomy, hemodynamic support, and correctly intravascular imaging. So the main finding of this study is that the observed 30-day mortality in this patient population was 5%, very similar to the STS predicted and half of what the cardiac surgeon was expecting if he had treated by means of surgery this patient population. Of course, total death rate due also to morbidities did increase from 1 month to 6 months, from 5.6% to 12.3%. Another important information coming from this study was that the clinical performance of angioplasty in this neglected patient population was very good. So several types of questionnaire, Kansas, Seattle, and also assessment of more objective ischemia were all in favor of angioplasty in this patient population, because patients that survived had a huge improvement in terms of symptoms and objective ischemia. Another important topic about this type of patient is if to support them or not. Again, as I said before, the guidelines are not helping us in understanding if to support or not. What I could find in the literature was this simple table, which was developed by a US center, which is showing very simply a scoring. If you have 0 with this scoring, you should not support these patients because you should not encounter any potential benefit. 1 to 2, you should consider patient by patient to support them. 3 or more, you should use any type of hemodynamic support. This is not the topic today of what type of support should we use in CHIP patients, but we can start from a simple aortic counterpulsation versus up to the venous arterial ECMO in the most complex patients with a good cardiac surgery facility, according also, of course, to the access sites. As I said, European and American guidelines are not helping us. An important information came from the PROTECT-2 study, which did not show an improvement in terms of clinical outcome if patients underwent revascularization with Impella as compared to aortic counterpulsation, but there was an increase in the hemodynamic support during PCI by means of Impella. This was an important, at least an important background for the future trial, which was PROTECT-3, which was presented and published last year by Bill. And this study was actually, like you probably remember, the ARS trial. So they just did a single arm prospective registry and compared it to the historical cohort of PROTECT-2 study. The difference here was that they implemented Impella, the 2.5 or the CP first. Second, they only selected centers with a good experience, where the learning curve in the usage of Impella was already at a good stage. So they compared this versus the historical group of patients treated with Impella 2.5 in PROTECT-2, showing an improvement, slight improvement, but significant in terms of MACE during the 3 months clinical follow-up. So let's come to our patient. We decided to treat first the RCA, which was easily managed by means of stenting. And then 3 days later, again, we usually go with the step-by-step procedure without incurring in a too long procedure. We decided to do an Impella-assisted angioplasty for the left main. In this case, we had to manage the aortic stenosis, which was, as I said, severe. So we did just a simple undersized balloon valvuloplasty. At that time, we didn't have cardiac surgery, so we couldn't do TAVI at our institution. So we did just a valvuloplasty with a 20 balloon, just to create some room for the Impella. Then we quite easily placed the Impella 2.5. And then we started dealing with the left main and the LAD and the circ. So it was a quite complex PCI. So we used a 7 French ABU 3.5 guiding catheter with a transradial approach, and we started using semi-compliant balloons. We did also a kissing balloon here, but we were not happy with the lesion preparation before implementing with stents. So we passed to scoring balloons, trying to create more crack in the left main. We use a 3/15 scoring balloon in the left main versus the LAD, but again, we were not happy with the lesion preparation. So we decided to use IVL in the left main. Luckily, the patient, thanks to Impella, of course, we were able to do a good job in preparing the lesion because the patient didn't have a big drop in the blood pressure during the inflations. So we had 4 inflations versus left main versus the LAD and 4 left main versus the circ. And this was the final result. So we were able to implant the first stent. We decided to use a BioSlim, which is a dedicated bifurcation stent, left main versus circ. So this is a stent which has a wide opening in the middle part, so we can easily treat the other part with a culotte or a T-stenting. And this is what we decided to do. We implanted a stent in the proximal LAD. and in the distal part of the left main in a sort of modified culotte. And then we managed the left main with a bifurcation kissing balloon and then a pot. And then we went on just addressing the proximal LED lesion. In this case, in order also to spare the total metal length, we use the scoring balloon again, and then a sirolimus coated balloon in a proximal LED 2.5 by 30, 10 atmospheres for 1 minute. And again, after lesion preparation, another sirolimus coated balloon in a mid-circ 2.5 by 30 for 60 seconds. This was the result, which was pretty good, more than acceptable, a good TIMI3 fast flow, good angiographic outcome in the left main. We did imaging, which was okay, and so we decided to finish the procedure removing the impella because the patient had a good hemodynamic support, a good hemodynamic performance after the weaning from impella. Then we brought the patient to the ICU. We were quite happy about what happened. We were talking with the relatives of the patients. We were just outside of the ICU, but we were called back in the ICU because the patients had a sudden groin pain with an immediate drop in the blood pressure. Patient came to the ICU with 130 systolic pressure, and the pressure dropped after less than 1 hour to 80. So we did a very fast echo scan, and we saw a perforation, which then the patient was then brought back to the cath lab for confirming this perforation with a right femoral access. And this is what we found. And then we decided to implant a covered stent, which was quite easily advanced into the common femoral artery. And then the patient was brought back to the ICU for a 5-day stay, and then another 3 weeks total in the hospital, then a few days more in the rehabilitation, and then the patient in the end was discharged. So my conclusions, a no-option patient is not only a high-risk patient, either from the clinical and from the lesion and procedural point of view, but is a patient that must undergo a heart team discussion. So we should not just deliver the patient to the cardiac surgeon, but discuss about which are the options. Okay, cardiac surgeon doesn't want to operate a patient. Okay, let's discuss together about which are other options for this patient. No option patient should be allowed entering a CHIP program, but only in a specialized tertiary center with a good ICU, good relation with an anesthesiologist. This is something that probably is quite common in the US. I have to admit that it is not so common in Europe, at least in many centers. This is something that it does not happen. So this patient, in my opinion, should not be treated in such type of centers. Then you have to provide them a state-of-the-art PCI by means of technical devices, by means of correct analysis of the imaging, and whatever we can use in our patients in the cath lab. All of these patients should not be forgotten by the interventional cardiologist and the physicians that are following this patient, but should undergo a strict multi-specialistic follow-up for potential complications, because many complications doesn't come out immediately after the angioplasty, but can come after a few days. And the goals of these patients are not only to reduce mortality, which is of course the most important issue, but also other parameters, also including the quality of life, should be very well managed. And then I'm done. Thank you for your attention.
Bernardo, thank you so much. And I think you highlighted, the case was great to use this case to highlight sort of an important patient group who I kind of feel very strongly about, and I have some very strong comments I'm going to share later. But I wanted to give some of my team an opportunity to maybe discuss their thoughts and kind of talk to you a little bit. So I'm going to see who's on, but maybe I'll start while they're warming up. So I have like a huge issue with the terminology surgical turndown here in the United States, okay? Because when it's like almost a label people get given you. And when you get given the label, either two things happen, right? Either one is people say, oh, no, it's a surgical turndown. So this is so high risk. We're not going to touch the patient. And the patient doesn't even then get presented to the interventional team. So we've had this happen often. Patient comes in, they're seen by a non-invasive cardiologist, sends it to the cardiac surgeons, and they say, no, we can't, we don't want to do this case. So it becomes a surgical turnout. And then the patient gets sent home on medical therapy instead of being sent to us to say, can you do something? All right, percutaneously. So that's the one thing. The other thing I see happen is that, oh, it's a surgical turndown. So whatever happens, happens. Like, I can take on more risk. I can, the patient was turned down by surgery. So there's no backup support. There's no ECMO for this patient. So I can do as high risk PCI as I want. And there's, it's a surgical turnaround. So it's almost like it gives, some people feels like it gives them free reign to do very complex PCI without any responsibility about the outcomes. So those are like two of the things, extremes I've seen with this label, surgical turnaround. So I hate the label because, I think rather than surgical turndown, it's a patient who is better served by percutaneous revascularization than surgical, and because they have comorbidities, right? So I don't like the terminology because of these two extremes I see.
Yeah, but I think this is what is happening in many centers. We have seen the middle way, which is quite clearly shown by the study Optimum, which is showing a very good 1 month mortality, which is half of the one predicted by the cardiac surgeon. And all of them was done prospectively and then assessed also by the core lab. And this is very important. So the quality of the study is very good. And then we have the two other areas, which is the left and the right. You can choose which is the left and which is the right. But as you said, these are two areas where the interventional cardiologist is left alone or is feeling alone. He's feeling alone because he doesn't want to take the responsibility of treating these patients. Nobody wants to take this. And we have seen that these patients have a very high mortality in the first study, double than patients normally treated by surgery. And then on the other hand is the interventional cardiologist that says, okay, I want to treat this because I'm good, and nobody wants to treat this patient, so I can do it. Okay, I'm good, but I don't have the environment for treating this patient. And also in this case, you have a lot of complications and mortality.
Yeah, absolutely.
But maybe the guidelines, Azim, only the guidelines could help us, but with paucity of scientific data, it's difficult also to recommend.
Absolutely, but also because there's never going to be, the guidelines only change the indications based on randomized data, right? I mean, you like your patient, what are you going to randomize the patient to? Nothing. So death.
Nothing.
This is trying to save a life. I mean, come on.
Yeah.
So the guidelines, unfortunately, are not going to help us, I don't think. But I wanted Katie to make a comment. So Katie, and hopefully can come off mute, but she is someone who feels very strongly about complex PCI. She does a lot of our complex PCI, and she's one of our top CTO operators. Katie, do you have any comments?
Well, I was just going to say, Azim, you sort of stole my main question / observation of how like patients are at the mercy of what the first person who sees them is. And like, if you meet somebody who says this disease is too complex because it's a bifurcation left main, which we all know is like treatable by most interventional cardiologists who have training in that area, that's all they get. And I really struggle with, even in like single center groups where there's maybe not a lot of communication, like how to get patients the ability to advocate for themselves, or to make it a more like well-known thing amongst cardiology that these patients have other options. So that was sort of my main comment, but you like very astutely already commented on that. So I guess my other question was how you guys in Italy talk to patients about whether or not to revascularize the CTO territory. It's a thing that comes up a lot for us, like in surgical turndowns. It's, I would say, at least most places, fairly common that they'll get their non-CTO lesions treated, and then the CTO lesions go to medical therapy because of a paucity of data And I feel pretty strongly that in surgical turndown patients who would otherwise have gotten complete revascularization with bypass surgery, that we should offer them the same result if possible. Of course, there are caveats in the setting of like very severe other end organ disease, but how do you guys have that conversation?
Well, CTO actually is not one of the main reasons for not operating a patient. In Italy, at least in 80% of the centers, there is maybe 70%, yeah. There is at least one expert on CTO, and so they usually treat that CTO by themselves after internal discussion, of course. So this is not an indication for sending the patient to cardiac surgery. Usually our cardiac surgeon do refuse patients for comorbidities and for the age, not for technical aspects of the PCI. Usually technical difficulties are managed by the interventional cardiologist. As a general rule, of course, it's not. Oh, I have my voice coming back. Okay, it's just a general rule, but the main indication for not operating this type of patients is clinical.
Interesting. That's fascinating. Because Azim, tell me what you think. I feel like it's often a combination of the patient comorbidities and coronary complexity that end up in the conversations, at least in the US.
Yeah, very much so. I think it's a lot of its complexity and then targets, and what the targets are like. That are the reason. But I think, yeah, I mean, the other thing, we had to do, and we haven't been completely successful, Bernardo, is, we, in the last couple of years, we created a heart team meeting, a weekly heart team meeting to discuss complex coronaries. And in one of the things we've asked people to do is to never send, if a patient's turned down for surgery, to always present them at that meeting. Never send them home without having them present at the meeting. And there will be occasionally, you will find a case where you go, even PCI is not going to benefit this patient, right? Because they're too frail, they have too many comorbidities, and they're going to do poorly. But often, many of those cases will benefit from percutaneous revascularization. So that's something we've tried. It's helped, but there's still occasionally patients who get sent home without being discussed in a heart team meeting. And I think it's really important what you mentioned is, the sort of heart team approach to it. And for the surgeons not to feel bad if they can't offer the patient, to realize that we can. Because I've heard surgeons say, oh no, we can't revascularize this patient, so there's nothing to be done. All right, there's no options for this patient because we can't do surgery on. And to me, that's incorrect. I mean, because PCI has gotten to a level where there's very little we can't do. We may not want to do it, or it may not benefit the patient, but technically we can do just about everything on coronary arteries. So I hate this comment, oh no, and I see it in coronary disease, I see it in valvular disease. I recently, we were on our heart team, we presented a guy who, post-MI, had 25-30% ejection fraction, ischemic MR, and we presented him on the heart team meeting, and no one wants, the surgeons turned him down. So I go, I'll clip him. And the surgeon sends me a text. He said, don't do it, he'll die. Because the surgeon couldn't do it. And I think the patient's now home. He's 4 months out. He's doing well, right? We have to.
But this, Azim, this happened in Milano or
in
New York?
New York. Yeah, New York.
Okay.
Yeah. So we have to be honest, I think, and humble enough, right, to say when there's something that we can't do, but could still benefit the patient, maybe somebody else can do it. So I see it between surgery and intervention, and I also see it in intervention all the time, where someone gets the patient and go, "Oh, that's so complex," and they realize they can't do it. So they don't call Katie, or they don't call their complex PCI operator, because then it's almost like they're saying they're maybe not good enough. No, we just, in every team and group, there has to be some people who are better or more focused at doing certain things. And we have to be humble enough to say, you know what, I can't do it, but Bernardo can do it. Katie can do it. Chris can do it. Somebody else who has specialized in that will do a good job at it. All right. I wish we can go beyond that.
Yeah, I agree. Totally agree.
Let's see. We have a couple of more questions. We'll go to Andrea and then Chris and then Manaf.
Hi. First, thank you for this very interesting talk.
Hi.
And also the case. It was very, very interesting. I've just one question for you. I know they are already surgical turned down, so it's not about having cardiac surgery, but even considering that, of course, these procedures require very skilled operators like you, do you think that since these are very complex patients, especially from a clinical point of view, should they be treated in a tertiary care, or where there is also an infrastructure of heart failure and other colleagues who can take care of them after the procedure, even if there is no cardiac surgery, because that's not, of course, the point for these patients?
Yeah, this is a very important message that I would like to deliver, and thank you for underlining this again. Of course, my answer would be yes. The importance, it was one of my last comments on the case. The importance is not only to have a highly equipped cath lab, but also to have a very good team working, a very good relation with the ICU guys, with the anesthesiologist, and then to discuss and to talk. Because the path of these patients is not only an operative act, but is before how you reach it, and mostly after. In my experience, in my life, I've seen patients dying or having complications because they were treated well in the cath lab, but in the following days, they were not managed very well. And this is something that is totally stupid, because we take a huge risk in that moment, and then we have to follow these patients. If other colleagues do not do that, we should do them as interventional. We should do that as interventional cardiologists.
Yeah, I think that's, I was talking earlier about the difference between interventional surgeons, but one of the things, because of structural, I got to work a lot with surgeons. And one of the things they match better at us is if they do a procedure on the patient, they will see that patient every single day until that patient goes home. All right. They will be involved in every decision that happens on that patient. And a little bit, we have to be careful in intervention, of not becoming just technicians. One of the terminologies I hear used here in the US, I've also heard it in Germany, is angiographer. People call themselves angiographers. I hate that terminology.
Yeah.
It should be banned. Okay, because first of all, we're doctors, we're cardiologists. We're not angiographers, we're not technicians, we're not radiologists. And so as a cardiologist, it's your patient, and you should see your patient every day until they go home. Right? That should be your responsibility. If you can't, you should check the chart, you should send somebody else, but that patient should be followed by you every day.
Yeah, this is a very important point. It's not only for the patient, but it's also for you.
Yeah.
It's also important for you, also from the legal point of view. You can have consequences if you don't follow the patient. If you create a good relation, even if it wasn't your patient, but is a new patient, it's important to create this type of relation with the patient and with the family.
Yeah, couldn't agree more. So the fellows, don't ever use the word angiography in front of me. I'll get very upset. Chris is one of our fellows. Also, I think with a lot of interest in complex PCI. Chris, you have any comments?
Chris.
No, it's a great talk. Yeah, I just had a comment, just highlighting the importance of having a heart team meeting, because thus far in my training, I did my general at Oshner, New Orleans, and up here. I've seen, increasing rates of surgical turndowns, right? Surgeons becoming less and less aggressive in a lot of these patients. And, the heart team meeting kind of keeps these patients from getting swept up under the rug, which I've also seen, which is unfortunate. I like your slide about, which patients do you want to use support with? Because sometimes I know it can be kind of a difficult decision with those patients who are kind of like in the intermediate zone, whether should I use support, should I not? And, but regardless, during those procedures, planning ahead by, like you did before, doing a growing shot is really important, because I've also seen, some catastrophic things of people not looking at the femoral arteries when these patients are crashing. And you put support it, so the whole process of planning ahead with that is important. So I like that slide.
This is thank you. This is very important because, in your center, you are a referral center for structural, so you don't have problems in creating big holes, which are relatively big as the one for Impella. Okay, but in other centers, like in my previous center, when I brought there the Impella for the first time, people were, accustomed to use 7 French for some complex PCI, some CTO. That's it, not the 14 French whole. So when you take these into account, if to use a support or not, you should also think about the management of the big whole. In this case, we did a mistake, in my opinion, because we used a Manta device. I don't know. This is another topic. But I would like to know which is the opinion of Azim about this device. But I have to say that we had complications in several cases. I can remember 4 or 5. And the problem with Manta is that the complication does not occur immediately, because this is something that you can see with the ProGlide. Okay, ProGlide, the problem. Okay, with the Manta, it comes even hours later. Once I had to come back to the hospital during the night because of the bleeding, which came out after 8 or 9 hours. In this case, less than 1 hour. So this is something that you should also take into consideration when you decide to put a big hole.
Yeah, I agree. I think there's randomized data now. When you look overall at the complication rate between ProGlide and Manta, or Perclose and Manta, it's the same in these randomized studies, but the type of complication differs, and that's my problem. And it's exactly what you said. When a ProGlide fails for me, I know in the cath lab. I'm there, I go with the balloon, I check, I put a stent in. The problem with the Manta complications is that they happen late. They can happen hours later, so anywhere from 2 to even 12, 16 hours later. And the problem is then someone may not notice the complication, right?
Yeah.
So, Sushil at Columbia, they stopped using Manta because they had a patient die in the middle of the night from late bleeding. Groin was fine. So I think there's a role for it in some very calcified arteries, because I think it works a little bit better plug, but I don't use it routinely at all. But I think it's important to know how to use it for some patients, but I don't use it routinely because I'm concerned like you about complications. I want to know my complications immediately.
Yeah, and you can fix it immediately. Yeah,
exactly. Manaf, do you have any comments?
Yeah, thank you. I have to be honest, I missed most of the talk because I was seeing a patient, but I look forward to going back and watching some of the slides. But my question for you is a little bit more of bigger picture, or more of a philosophical, I guess, question. Obviously us as cardiologists and our surgical colleagues are here for the same purpose, to help our patients and revascularize them. But for whatever reason, at times, as you know, there can be things that get in the way of our communication and in the way of our ability to work together as a team. And I'm just wondering what strategies you have, both on a personal level and, even as from an institutional level, how you can kind of foster this kind of open communication and really to keep at the forefront our shared, goals, and not let some of these things that I think, unfortunately, in the end up hurting patients, miscommunication and ego, and these things that can sometimes get in the way, whether we like to admit it or not.
Yeah, it's difficult to answer to this question. I can talk about my experience visiting many centers and seeing. I always wonder how is the equilibrium between the interventional cardiologist and the cardiac surgeon. It's an important one. I think that if it's left to the physicians, head of cardiology, head of cardiac surgery, you can be lucky or you cannot. You can be very, very unlucky. Because if you're unlucky, they fight each other. But if they don't fight each other, they don't care about what's happening below. Okay, maybe below they fight each other, or they don't have a good relation. In these cases, I truly believe that the administration should put a stop. This is something that in Italy is quite impossible, because the administration is not entering into this, mostly in the public hospitals. There is a concretion of equilibria that are difficult to manage by the administration itself. But in my opinion, they should do something, because in the end, the patient is not managed well. If there is this good relation at the beginning between these two entities, it is much easier. But if not, the goal is to create it. It's a very general comment, but a sort of philosophical comment. But the goal is there.
Yeah. Bernardo, thank you so much. It was a great discussion, an important topic. And I like the way you use the case to bring out such important points about, heart team discussion, about management of patients pre and post procedure, and how we can, make the right decisions for our patients. So it's always good talking to you. I do hope you'll come back and talk to us about drug-coated balloons later this year.
Okay, whenever you want.
Agent is going to be approved this year in the US. And we also, as you know, we're both involved in some other drug-coated balloon studies that are global and that will involve the US too. So I think the more we can teach our colleagues here and share the experience we have, the better it will be.
I will do it. It will
I'll
be a
see you
pleasure.
around. Okay.
All right.
Yeah.
Bye-bye. Ciao, guys. Ciao.
Bye, everybody.